A spinal cord stimulator trial is a test, not a small version of the treatment. Temporary leads are placed, stimulation for a short period. And the question being answered is narrow. Does this change your pain enough and in the right way to justify implanting a device? The trial exists because stimulation cannot be predicted from a scan or an examination. There is no image that tells us in advance. There is no image that tells us in advance how your nervous system will respond. The only reliable way to measure what happens. So what is the trial screening for? Patient selection for spinal cord stimulation has predict a poor response. Those factors include psychological state, smoking, and opioid use. The trial complements that clinical screening. It does, not replace it. Consensus guidance also recommends that a formal process to elicit patient information and to gauge acceptance of the chronic pain state within a multidisciplinary framework be considered before proceeding to stimulation. In practice, that means the conversation before the trial matters as much as the trial itself. Now, let me give you the numbers and let me be careful about who they describe. A single institution reported outcomes for 505 consecutive stimulator trials. The population matters when you read these figures. Mean age in that series was 67.5 years, and 64.2% of the patients were female. In that series, 86.1% of patients achieved trial success, and 77% went on to permanent implantation. The gap between those two numbers is worth sitting with. A successful trial and a decision to implant are not the same event. Some people who respond still choose not to proceed. Response is also not uniform across diagnoses. In the same series, patients with diabetic neuropathy had the highest trial success rate at 83.3%. Patients living with CRPS had the lowest at 67.6%. That is not a reason to rule out a trial for CRPS, also called reflex sympathetic dystrophy or RSD. 67.6% is still a majority. It is a reason to go in with calibrated expectations and to have the rest of the plan. Had the highest trial success rate at 83.3%. Patients living with CRPS had the lowest at 67.6%. That is not a reason to rule out a trial for CRPS, also called reflex sympathetic dystrophy or RSD. 67.6%, leading cause. Lead migration and infection were the most frequent complications. 4 things were statistically significant predictors of explantation in that series: tobacco use, depression, chronic opioid use, and falls after implantation. 3 of those 4 are modifiable before a trial is ever scheduled, which is an argument for treating the run-up to the trial as part of the TAD. Treatment. Can anything you do beforehand improve your own odds? Possibly. That is the honest answer. What the series identified were predictors of the device later being removed, not a demonstration that changing them changes your result. But they are worth raising early rather than late. And support for that includes counseling for chronic pain. And if you are living with CRPS or RSD, the layered plan matters more, not less. CRPS and RSD treatment is its own conversation. With CRPS or RSD, the layered plan matters more, not less. CRPS and RSD treatment is its own conversation, and it should be happening alongside this one. On medication, in that same series, opioid use decreased in 58.9% of patients. That is a meaningful figure for anyone hoping to reduce their medication burden, but it is an outcome to work toward with a prescriber. It is not a switch the device flips. How that reduction is managed sits under opioid stewardship, and it should be planned, not assumed. Here's the part I would want you to take with you. A trial that is not clearly defined in advance produces an ambiguous result. And an ambiguous result is hard to act on. Before the leads go in, it is reasonable to ask 4 questions. What threshold are we using to call this a success? And how will it be measured? Besides pain intensity, what function are we tracking? Walking tolerance, standing time, sleep. What happens if I respond partly? Is the answer more programming a different target, or a different treatment altogether? And which of my own risk factors should be addressed first? Smoking, mood, medication, fall history. Success should be a predefined threshold of improvement, agreed before the trial starts and measured against how you actually functioned during the trial, rather than recalled afterward. If a partial response redirects the plan, the alternatives are the same image-guided options used elsewhere in the practice. Among them, epidural steroid injection, nerve blocks, peripheral nerve, seek urgent assessment or call 911 for fever, chills, or spreading redness, swelling or drainage at the lead or incision site, new or worsening weakness in the legs, new numbness in the groin or inner thighs, loss of bladder or bowel control, severe unrelenting back pain that is different from your usual pain. Any of the above together, call 911 or go to the nearest emergency department. At an Institute Center for Interventional Pain Management, painmd.tv/appointment. Call 314-481-5000, text 314-886-5902, no referral needed.